Autism Spectrum Disorder manifests as a highly variable neurodevelopmental spectrum, encompassing a vast range of distinct behavioral presentations. Globally, the prevalence is increasing rapidly. Recent research tracks it at 1 in 68 children, and genetic heritability sits at roughly 90%. Practitioners must map this highly diverse behavioral reality onto a strict, standardized diagnostic framework to assign an accurate severity level and determine the degree of support required. The DSM-5 diagnosis rests on a diagnostic dyad, two mandatory clinical pillars. The first pillar requires persistent deficits in social communication and social interaction across multiple contexts. The second pillar mandates the presence of restricted, repetitive patterns of behavior, interests, or activities. Both sets of symptoms must be present in the early developmental period, though learned coping strategies may mask them until later in life. Identifying both halves of this specific dyad allows practitioners to differentiate autism spectrum disorder from isolated speech or general developmental delays. Social communication deficits encompass complex interpersonal challenges distinct from simple delays in verbal speech. Red flags appear early, often starting with an infant failing to respond to their own name by 12 months of age. As the child reaches the toddler stage, they may lack functional single words by 16 months and miss the milestone of combining words by 24 months. When speech emerges, clinicians look for structural abnormalities like echolalia, the continuous repetition of phrases, alongside idiosyncratic jargon and unrelated answers to questions. Deficits also extend to nonverbal communication, frequently presenting as poor eye contact, a lack of facial expressions, and an inability to use gestures. These children are sitting in close proximity yet remain completely isolated. This demonstrates a core failure of back-and-forth emotional reciprocity, distinct from mechanical vocal delays. The second diagnostic pillar focuses on restricted and repetitive behaviors, which often manifest in a child's environment as a specific type of play. Children with ASD often replace varied imaginative play with mechanical, stereotyped motor movements. This is a classic presentation of simple motor stereotypy, a child meticulously lining up toy cars along a sofa. We see the same rigid adherence to placement here, with a perfectly straight line of toys and shoes situated next to the child in bed. This spatial rigidity crosses different object types and scales, such as this sequential arrangement of large ride-on toys. An inflexible insistence on sameness drives these behaviors. Small environmental changes often trigger extreme psychological distress. These rigid behaviors function as an active coping mechanism. The child uses them to assert control over an environment that feels overwhelmingly unpredictable. Within the second pillar lies another critical axis: unusual reactivity to sensory aspects of the environment. Hyperreactivity often presents as extreme auditory sensitivity, where a child covers their ears to block out ambient sound. Tactile sensitivity is also common, such as an inability to tolerate the physical texture of specific clothing items. Conversely, hyporeactivity causes children to seek out intense, specific physical stimuli, such as watching the spinning wheels of a toy car at eye level. These sensory disturbances are core diagnostic drivers and frequently trigger the severe behavioral meltdowns seen in clinical practice. Behavioral observation is driven by a deep-seated neurodevelopmental divergence. The etiology is heavily genetic, involving a high concordance rate in monozygotic twins and at least 3 to 4 specific implicated genes. Environmental risk factors include older maternal and paternal age and prematurity. Clinical data confirms that vaccines are not a causative factor. Because biological markers are absent, formal diagnosis requires comprehensive parental history and structured tools like ADOS. Accurate diagnosis relies on the clinician's ability to map that history and observation directly against the two pillars of the DSM-5. No pharmacological treatment exists for the core symptoms of ASD. The frontline standard of care is early intensive behavioral intervention, or EIBI, initiated before age 6. This intervention requires 25 to 40 hours per week of highly structured work. Therapies utilize applied behavior analysis principles, favoring naturalistic, play-based interactions. A primary clinical goal is implementing positive behavior support, specifically reducing maladaptive behaviors and providing actionable tools to navigate sensory triggers. Early intervention equips the child with functional behavioral skills necessary to adapt to complex societal demands. Medication serves a strict adjunctive role, utilized to treat severe, specific comorbidities. For cases of severe aggressive behavior, clinical practitioners may carefully utilize small, targeted doses of atypical antipsychotics like risperidone or aripiprazole. Standard pharmacological protocols also routinely address other associated conditions, including the use of melatonin for sleep disturbances and methylphenidate for comorbid ADHD. SSRIs are utilized for patients presenting with comorbid anxiety disorders or obsessive-compulsive traits. Pharmacotherapy provides a baseline physiological stabilization required for intensive behavioral and social therapies to take effect.